We've already seen the natural history, some of the microbiology and pathogens of tuberculosis extensively in the previous video, but in this particular section, we are going to start with the clinical features of tuberculosis. Tuberculosis per se, you can split into two. One is called a pulmonary tuberculosis and second one is extrapulmonary tuberculosis, where pulmonary form is going to be the most common. But the moment you call tuberculosis, almost all forms, whether it's a pulmonary or extrapulmonary, you're going to get this constitutional symptoms, which is very, very important to understand. So these constitutional symptoms are typically due to the cytokines from the T helper 1 response and the granulomas, especially the TNF alpha. That's the main reason why you get this constitutional symptoms like fever, weight loss, night sweats, malaise, fatigue. All these things will come under these constitutional symptoms only. This is very characteristic of tuberculosis, especially in countries like India where tuberculosis is extremely endemic. But let us see what will be the features of pulmonary tuberculosis. I told you more than 80% of the case of tuberculosis will be pulmonary only. And these patients also will have constitutional symptoms, all right. At the same time, they are going to produce productive cough. But remember, there are variants where you typically have dry cough only, even in a pulmonary tuberculosis. But all this depends. So productive cough is a common entity in India. That is due to cavitating lesions. At the same time, they can develop this hemoptysis, plus or minus hemoptysis, which is again a very important feature. The hemoptysis and productive cough both is very, very classical, especially if the patient is having a cavity. Whenever the patient is having a cavity, there is a lot of risk of producing productive cough and hemoptysis. Why you get hemoptysis in a cavity? Because this cavity produces dilation of pulmonary arteries. Dilation of pulmonary arteries, pulmonary vessels, and this dilatation of the pulmonary vessels is what we refer to as Rasmussen's aneurysm. Rasmussen's aneurysm. And this is the one typically that produces hemoptysis, and usually the bleeding due to Rasmussen's aneurysms will be only mild to moderate. It won't be severe. It won't be massive usually. Only mild to moderate hemoptysis because it's a low pressure system, this pulmonary vessels, and this is very common in tuberculosis. They can result in massive hemoptysis, but very, very often they will produce only mild to moderate, some small amounts of blood that is coughed out. But on the other hand, if you are going to involve the bronchial vasculature, bronchial vessels, the hemoptysis will be usually very severe, ranging from moderate to massive hemoptysis. But here it is Rasmussen's is because of pulmonary artery aneurysms and pulmonary vascular aneurysms, and that is the reason why you get this mild to moderate hemoptysis only. So these are some of the features of pulmonary tuberculosis. But chest X-ray wise or CT wise, imaging wise, what you're going to see? Highly variable, you can see any presentation, but classical presentations are forming a cavitatory lesions, interstitial infiltrates, consolidation, ground glass opacities, nodules. Especially one typical form of nodule that is very classic of pulmonary tuberculosis in India is what we call it as tree in bud appearance. You know how this tree in bud appearance comes. We have already discussed in the section on overview of ILDs. There I have explained you how you get a tree in bud. So you have a lobular bronchus like this. You have a secondary pulmonary lobule. And if you have an impacted lobular bronchus with some infectious material with surrounding centrilobular nodules in the other secondary pulmonary lobule. So this is what is going to classically create this tree in bud appearance. Clear? So this is very classical of TB, even though it can be seen in other conditions like bronchiectasis, very, very classical of TB, especially in highly endemic countries like India. So with this, let us move on to some of the imaging findings, what you will see in tuberculosis. So the first one is again extremely classic for tuberculosis. This is a cavity that you are seeing, and this is the upper lobe. And again, this is seen in the chest X-ray also, your upper lobe cavity. Along with that, you have a surrounding consolidation. Here also you can see there is a surrounding consolidation. So this upper lobe cavity with consolidation, like definitely it is a tuberculosis unless proved otherwise, especially in India. Here you can see multiple cavities. You can see cavity 1, cavity number 2, cavity number 3, cavity number 4. So you are seeing multiple cavities here along with infiltrates with little bit of airspace opacities. These are small consolidations. Along with it, you are seeing a lot of infiltrates in the upper zone. So this is again very, very classical of a tuberculosis, multiple cavitating lesions with especially seen in the upper lobe with infiltrations and few areas of small consolidation, very classic of tuberculosis. And this is the so-called tree in bud appearance, where you can see many areas where you are seeing, where one area, if you want to tell very classically, yeah, here you can see an impacted bronchus here, and you are seeing a lot of surrounding centrilobular nodules. So this is again very typical tree in bud opacity, and you can see a lot of tree in bud opacities in this particular CT. And again, this is so classical of tuberculosis. This is a typical miliary tuberculosis, where you can see a lot of miliary nodules distributed throughout the lung. And you can also describe this miliary tuberculosis in the same patient with the CT, where the nodule is supposed to be random distribution. They will not be perilymphatic, nor they will be centrilobular. They will be in a random distribution. That's what you are seeing in this particular CT. And this is what we refer to as the Mendel-Mantoux test, or the tuberculin sensitivity testing. And this is again a very important image for the exams. Remember, these are the images that you have to know for your clinical practice. Even though it's less commonly asked in exams, I don't know why tuberculosis is often an underestimated topic, but that is something you encounter so commonly in your day-to-day practice. So you have to know about all these images very nicely. Then we are moving on to the next group of disorders called extrapulmonary TB. So what is the most common site for extrapulmonary TB? It is going to be the lymph nodes. Lymph nodes are the most common site for extrapulmonary TB, and that's what you're going to see. The first manifestation, that is lymphadenitis. And what is the most common group of nodes that are involved in lymphadenitis? They are the cervical group of lymph nodes. These are the ones that are most commonly involved in lymphadenitis. And many times, these lymph nodes, like they join together because of the caseation, and they give a matted appearance or a matted consistency. More than appearance, it's a consistency that you look for. It's a matted consistency because this caseation may allow these lymph nodes to join together and they form a conglomerate mass like appearance, and you can see them by touching, and that's what we refer to as a matted appearance. This enlarged cervical nodes is typically referred to as scrofula. Sometimes this scrofula might extend into the surrounding skin, adjacent skin. So this extension of the scrofula, that is the lymph node inflammation and infection, extension to adjacent skin, if it is present, we are going to call it as scrofuloderma. So we're going to call it as scrofuloderma. Remember, one more point, that this lymphadenitis may be caused by certain non-tuberculous mycobacteria also. And one of the important non-tuberculous mycobacteria that causes this kind of lymphadenitis and scrofula and scrofuloderma is Mycobacterium scrofulaceum. The name itself tells you that's called Mycobacterium scrofulaceum. Actually, it's a non-tuberculous mycobacteria. You have to be very careful about that also. Clear? So let us see some images. You can see this is a typical patient who's having a scrofula. You can see, isn't it? So this is a painless lymph node mass that is present in the cervical region, which is an enlarged lymph node. And if you touch them, most of the time you'll have a matted consistency. Apart from that, I didn't tell you the fact that these nodes are going to be absolutely painless and non-tender. Clear? And these patients may have constitutional symptoms or may not have constitutional symptoms. That is different. And most of the time, they will be unilateral nodes also. It can be bilateral, but very commonly, classically, it will be unilateral nodes only. And they will be enlarged and swollen. So this is classical. And they might have a matted consistency. Suppose when you call a scrofuloderma, when you are going to call a scrofuloderma. So this is the typical example of a scrofuloderma that you're going to see. You can see this is a lymph node that is enlarged here in the neck, and you can see the extension of the infection and inflammation into the adjacent skin or overlaying skin. So this is what we typically call as scrofuloderma. Diagnosis of this lymphadenitis is quite simple because you are just going to do an FNAC and send that sample to GeneXpert. You can do AFB also, but GeneXpert is relatively more sensitive and specific. So see GeneXpert and find out that it is Mycobacterium tuberculosis or even Mycobacterium scrofulaceae. So that's what you're going to do. Just examination of the FNAC under microscope alone, cytology alone, will not yield you anything. You will see only benign cystic contents most of the time, and AFB may or may not be positive, but ideally in the current era, you do a GeneXpert. Or maybe you can biopsy the entire lymph node in the form of an excision biopsy. If you have suspicion of malignancy, then if you see, you will be seeing that characteristic caseous necrosis. That is also a sign of tuberculosis, clinically diagnosed tuberculosis. And you can send for culture and that will grow some Mycobacterium tuberculosis. So in any way you can diagnose, but currently what we prefer is using this GeneXpert for lymph node samples which are highly sensitive. Even the government of India recommends using GeneXpert samples for, FNAC samples for GeneXperts, especially if it is obtained from the lymph node, which is going to have very high yield and high sensitivity. Next, tuberculous pleurisy. This is another form of extrapulmonary tuberculosis. Remember, they may have associated pulmonary tuberculosis or they may not have associated pulmonary tuberculosis. You can't predict. So, but tuberculous pleurisy itself has some characteristic clinical features in the form of, like, they will have dry cough most of the time, because if it's isolated tuberculous pleurisy, this will not produce productive cough, they will produce only dry cough. Sometimes they can come with intractable dry cough also. And they will have pleuritic type of chest pain. Pleuritic type of chest pain. Along with that, they are going to have the constitutional symptoms. Constitutional symptoms. So these are the usual features of a TB pleurisy. When you examine and you do a chest X-ray or a CT and imaging and see, you are going to get pleural effusion in the involved area. And this forms the base of diagnosis, because you are going to take the pleural fluid sample, and if you see the pleural fluid and analyze the pleural fluid, they are going to be of exudate with very high lymphocyte count, with extremely high lymphocyte count, more than 50% usually. In fact, sometimes 80 to 90% will be full of lymphocytes only. And in the fluid, your ADA levels will be more than 40, and that will clinch the diagnosis most of the times. Clear? Suppose if ADA is less than 34, it rules out the tuberculous effusion diagnosis. It's not possible. But if it's more than 40 in India, it's almost tuberculosis unless proved otherwise. So this is what we refer to as a clinically diagnosed tuberculosis. Without any microbiological evidence, still you can diagnose tuberculosis by just seeing ADA more than 40. We call this term as clinically diagnosed tuberculosis. Remember, AFB yield is very poor, so you often get negative test only with AFB. And GeneXpert is typically again not recommended. Cartridge-based nucleic acid amplification test, that is GeneXpert, is not recommended for use in pleural fluid by many authorities in India and WHO, just because the sensitivity and yield is very poor. If you still have suspicion, all borderline features, still you suspect TB heavily, then the only way out is VATS and do a pleural biopsy. If they ask you gold standard for diagnosing pleural TB, answer must be VATS guided pleural biopsy. That is the gold standard for diagnosing pleural tuberculosis, because you have the direct tissue evidence for diagnosing tuberculosis. So after knowing the TB pleurisy, let us move on to the gastrointestinal tuberculosis, GITB. Clear? So gastrointestinal tuberculosis results from swallowing of the organism. What organism you can swallow? It could be secondary forms by swallowing a Mycobacterium tuberculosis which is having lesions in the lung. So swallowing a Mycobacterium tuberculosis from the lung by coughing out and then swallowing again, that could be the cause. Or it could be a primary infection by swallowing Mycobacterium bovis through unpasteurized milk. Clear? So these are the two mechanisms where you can get gastrointestinal tuberculosis. Remember, this Mycobacterium tuberculosis swallowing causing GITB will result in ulcerative form very commonly, whereas this Mycobacterium bovis swallowing and resultant gastrointestinal tuberculosis will be hyperplastic form. So we are going to see what are the ulcerative forms and what are the hyperplastic forms of tuberculosis. But almost all the tuberculosis, types of tuberculosis, either it's an ulcerative form or your hyperplastic form, or it's due to bovis, or if it's due to Mycobacterium tuberculosis, doesn't matter. They affect the terminal ileum most commonly, the cecum and the terminal ileum extremely commonly. It's because of two reasons. One is the natural anatomy of the terminal ileum. In the terminal ileum, you have ileocecal valve, which is going to provide a very sluggish flow for the digested food. So the contact with the organism in the terminal ileum is more with the intestinal wall, so there is a more chance of infection there. Reason number 2 is the fact that the Peyer's patches is more in the terminal ileum because these organisms love the macrophages, where you have lots in the Peyer's patches in the terminal ileum. So there's a lot of probability that they infect the terminal ileum with the high incidence. So that is the reason why terminal ileum is infected very commonly, and this is the most commonly affected area in case of a gastrointestinal tuberculosis. And now let us move on to the differences between the ulcerative form and the hyperplastic form. Ulcerative form of tuberculosis and hyperplastic form of tuberculosis. First, ulcerative form, most common form, 80 to 90% will be ulcerative form only. It's the less common form, 10 to 20% only will be hyperplastic form. Clear? And there is some cases that will have combination of ulceration and hyperplasia. So these are called as ulcero-hyperplastic variety, but not so common at all. So, but you can see this kind of clinical variants in India. And you know this is due to Mycobacterium tuberculosis, and this is due to Mycobacterium bovis. And both is due to swallowing only, obviously. GATB means itself is to cause the infection by swallowing of the bacteria only. So here it is a secondary swallowing from an underlying pulmonary TB. Most of the time there will be an underlying PTB, and from that only you will be swallowing the bacteria most of the time. Here it's always primary swallowing, which means from unpasteurized milk. You are swallowing the Mycobacterium bovis. Remember, this PTB may be evident or may not be evident also. It's not a surety that PTB should be evident all the time. So there can be a PTB which could be occult that will not be evident at all in X-ray or imaging purposes. So be very careful. It's not like always the chest X-ray will be abnormal or CT will be abnormal in these patients. So which means a chest X-ray usually, commonly tends to be abnormal, but not always. But here the chest X-ray must be normal by definition, because there is no primary infection in the lungs at all. It's bovis, straight away it's going to infect only gastrointestinal tract only. So next, these patients tends to be having more virulent organisms. Organisms tend to be more virulent here. Here the organisms tends to be a little bit of lesser virulence. At the same time, the patient tend to be a little bit older with poor immunity. Here many patients will be younger and relatively more immunity. Clear? And when you do a colonoscopy, you're going to see transverse ulcers, because this vertical ulcers is caused by typhoid, Salmonella typhi. This transverse ulcers in the terminal ileum. That's a very important point. Transverse in the terminal ileum and ileocecal junction. Transverse ulcers. Note the word transverse. Then in hyperplastic variety, you are going to see chronic granulomatous lesions in the ileocecal region again. But they won't be ulcerative usually. Granulomatous swellings you will see in the ileocecal region. Clear? So how they're going to present clinically? Clinically, many of the patients will come with diarrhea, a chronic diarrhea most of the time. Plus or minus, they can also have bleeding PR. But whereas this hyperplastic variety, many times they come with features of obstruction, a subacute obstruction, like they will have abdominal pain with intermittent diarrhea. Very classic. And some patients may have an associated right iliac fossa mass also. That is because of the hyperplastic ileocecal region. So you might have a right iliac fossa mass-like appearance. And certain textbooks do tell one more fact, that ulcerative varieties tend to have more constitutional symptoms compared to the hyperplastic variety. That is because the organism is more virulent and they produce more cytokines in general. So constitutional symptoms may be more with ulcerative variety compared to hyperplastic variety, but none of these things are consistently proven in the trials. So even hyperplastic patients we do see with a lot of constitutional symptoms. Okay. So then there are some barium signs are there, which are very, very important. Some barium signs are there. So for example, typically you tend to get something called a Stirling sign, not very specific for TB, but it can be seen in Crohn's also. But let us see the named signs that are given for TB. Let us respect these signs. Stirling sign. So second one, you can have this string sign of contour. Again, not a very specific sign. Third one, gooseneck deformity. I'll show you all the images. Number 4, you can also get this Fleschner sign. We're not talking about pulmonary embolism here, for that matter, Fleschner sign. Or you can get, this sign is also referred to as inverted umbrella sign. Inverted umbrella sign. Clear? So these are some of the signs that you have to know for tuberculosis, GE tuberculosis. Let us see the signs now. So this is a normal barium swallow. This is a normal barium study. First one. So let us have an idea about how a normal barium study looks like. Then you can see here, this is what we refer to as something called a Stirling sign. So what is Stirling sign? It is nothing but the fast emptying of the barium, especially in the terminal ileum and the inflamed areas adjacent to the terminal ileum. So this is the terminal ileum, you can see, and this is the area adjacent to the terminal ileum, and this is the typical ileocecal junction, and this is the cecum. You can see there are a lot of areas which has poor barium filling. Like that streaks of areas means that area's barium is not filled, and here also you can see some areas which are not filled adequately with barium. And this is the Stirling sign, and this is typically due to irritation. Typically due to irritation. Why irritation? Because of the inflammation. Because of irritation and inflammation, the peristalsis will be faster in certain segments, and because of that, the barium will be pushed faster into the adjacent segment. So that is the reason why you have a less barium in certain areas in that particular zone. So this is what we refer to as Stirling sign. Along with it, you can see other classical changes also, like this ileocecal narrowing is there. Ileocecal narrowing. At the same time, you can also see the cecum is insignificant, and cecum is almost obliterated here. So this is what we refer to as Stirling sign. It's not a specific sign, it can be seen in Crohn's disease also. And this is one very important sign again. So this is what we refer to as gooseneck, relatively specific for tuberculosis in India, gooseneck deformity, where you have this narrowing of the ileocecal junction, all right. The terminal ileum is narrowed and the ileocecal junction is narrowed, and you can see the cecum is completely pulled up because of the fibrosis. This is what we refer to as a pulled up cecum. Pulled up cecum. What I'm writing is the cecum actually. So that's a pulled up cecum, and that is, like one of the important standard signs of the tuberculosis. So this pulled up cecum, clear? So this is again what we refer to as a gooseneck deformity. And you can see another sign. So these two signs are actually string signs of contour. You can see long narrow segment of small lumen. That is because of the fibrosis and obliteration of that area. So this is what we refer to as string sign of contour. Clear? Fine. And this one is what we refer to as the Fleschner's inverted umbrella sign. Inverted umbrella sign. So what do you mean by that? Here there will be widening of the ileocecal valve. So this is the ileum, and this is the widening of the ileocecal valve. So why you are having widening of the ileocecal valve is because of the damage and gaping of the ileocecal valve. Gaping, giving away, gaping of the ileocecal valve. So because of that, you are seeing a wider area that looks like an umbrella. So this is what we refer to as inverted umbrella sign, or otherwise called as Fleschner sign. So this is a different image. This is what we refer to as an abdominal cocoon or sclerosing encapsulating peritonitis that we'll see in a peritoneal tuberculosis, not here. But with that, we'll see what is this form. This form is a classic ulcerative form of tuberculosis. You can see multiple ulcers here, I think here, these areas. Lot of ulcers are seen. So multiple ulcerations are seen in multiple areas. This is a typical example of an ulcerative tuberculosis. Very commonly, this will be due to Mycobacterium tuberculosis. And this is a hyperplastic form. You can see a granulation tissue here. This is a granulation tissue. There's a granulomatous inflammation, and you are seeing a mass-like appearance here, isn't it? So this is what we call it as a hyperplastic form. Very commonly, this will be due to Mycobacterium bovis. So these are some of the images I want to show you. Clear? So of different types of tuberculosis. In that, know the named signs: Sterlin sign, gooseneck deformity, then your fleshness inward umbrella sign, and string sign of Cantor. So all these signs are very important to be understood. Fine. So now what is the difference between tuberculosis and Crohn's disease? So this is a $1 million question, because many times, despite all the efforts, it's very difficult sometimes to prove whether it's a TB or a Crohn's, because both behave sometimes very, like in a very similar way. That's why. So what are the differences that you can make out between TB and Crohn's? Typically, TB will involve terminal ileum. At the same time, they will involve the cecum also very commonly. Even though most commonly they involve the terminal ileum, they can involve the cecum also. But remember, in Crohn's disease, the terminal ileum is the characteristic site. Cecal involvement is extremely rare in Crohn's disease. Clear? Unless and until you have a Crohn's colitis, it's very, very rare to involve the cecum. Very commonly, they will involve the terminal ileum only, most of the times. Will you have an ascites? Ascites is very, very common in tuberculosis, whereas it's very rare in Crohn's. You don't get generally. And peritoneal inflammation and thickening. Peritoneal inflammation and thickening with nodularity, all these things are very common in tuberculosis, associated findings, but it's very rare in Crohn's. You don't get this peritoneal nodular inflammation or thickening. Next, what about the lymph nodes? Enlarged lymph nodes are very common in tuberculosis, not a feature of Crohn's, especially if these nodes are necrotic. With the above findings, whichever I told you, definitely it is diagnostic of TB. Necrotic nodes in CT, especially if you do a contrast CT, you can see a central necrosis, very, very classic of tuberculosis. Remember, central necrosis can be seen in other findings also, but in India, with all the colonoscopy findings, what I have shown, this necrotic nodes in imaging like contrast CT can be taken as tuberculosis unless proved otherwise. So, but in Crohn's, you don't get this kind of necrotic nodes and all. And lung involvement. Lung involvement may or may not be seen, but if it's there, definitely it goes towards a tuberculosis. In Crohn's, you never have a lung involvement. So why it should affect the lung? It's a disease of the GI tract. And vascular engorgement. Vascular engorgement and fibrofatty proliferation of mesentery. This and all you can see in the contrast CT. Fibrofatty proliferation of mesentery is very rare in tuberculosis, common feature of Crohn's. Finally, when you do a biopsy, what are you going to see? You're going to see caseating granulomas if it's a tuberculosis, but here you will see a non-caseating granuloma. And often remember, they will have a transmural involvement with skip areas. This again very, very classical of Crohn's. So these are the differences that you can make out between a Crohn's disease and tuberculosis. But often, even though theoretically it is very easy to differentiate, but practically speaking, we have a lot of hurdles in differentiating between a Crohn's disease and tuberculosis. With this, we can move on to the next type of extrapulmonary tuberculosis, that is tuberculous peritonitis. Like how we saw tuberculous pleurisy, now we are going to see about tuberculous peritonitis. So there are 4 forms of tuberculous peritonitis. One is referred to as wet ascitic type. Usually this is the common form that you see in the country, wet ascitic type. So which means they are going to produce ascites. And what will be the type of this ascites? Typically they will be producing a low SAG, high protein ascites, which means they are typical exudative ascites. Let me give you a glimpse of how you will classify the ascites. So 2 things you have to take in consideration. One is the SAG, that is serum albumin ascites gradient, that is more than 1.1, or if the SAG is less than 1.1. Second, based on the protein content, whether it is less than 2.5, low protein, or high protein, more than 2.5. So remember, whenever you are dealing with the SAG more than 1.1, it is always portal hypertension unless proved otherwise. Almost with 100% certainty you can tell it is portal hypertension only. But whether it's a sinusoidal hypertension or a pre or post sinusoidal hypertension is the one that you're going to tell by seeing the protein. So which means SOG more than 1.1 means it is portal hypertension. If its protein is low means you tell it's a sinusoidal hypertension. Very commonly it's cirrhosis. If it's protein more than 2.5 means you're going to tell it's a pre or post sinusoidal hypertension. So if SOG is less than 1.1, usually it gives rise to a diagnosis of either a nephrotic syndrome or a mixed edema sometimes. If SOG is less than 1.1 but protein is more than 2.5, low SOG but high protein ascites. Very classical of an X-ray. So where you will be having differential diagnosis of TB, very common in India, or a malignant ascites, or a secondary bacterial peritonitis. Please don't write SBP. SBP means spontaneous bacterial peritonitis. There is humongous difference between a spontaneous bacterial peritonitis and secondary bacterial peritonitis. Okay, we'll discuss later in the GIT and liver chapter later on. So, or you might be having a pancreatic ascites. So these are you categories. That's why I told you in the beginning itself, TB is going to have a high protein but low SOG ascites. That's why I told you. So these are your categories ascites in the first place. This is what the wet ascitic type is. But there are other ways to diagnose this wet ascitic type where you can tell ADA more than 40. Again, you can diagnose the tuberculosis in this particular example also. Second form of TB peritonitis is what we refer to as something called a fixed and fibrotic type, which is less common, not common compared to that of the ascitic type. So it will be very less common, where there will be involvement of the omentum and the mesentery. Because of the involvement of the omentum and the mesentery, you will result in matted bowel loops. Matted bowel loops. So this is the second form. Third form is what we refer to as a dry plastic form. So in this condition, you will have a fibrous peritoneal reaction. And peritoneum will go for fibrosis. You will have a fibrous peritoneal reaction. At the same time, lot of peritoneal nodules and adhesions. So this is dry plastic form. And finally, the fourth form, that is called a sclerosing encapsulating peritonitis. Sclerosing encapsulating peritonitis. This is what we refer to as something called an abdominal cocoon. You have a lot of differential diagnosis for abdominal cocoon and sclerosing encapsulating peritonitis, but in India, whenever we see this, we take it as TB unless proved otherwise again. Where the patient will have all the bowel loops that are matted towards the center. So you will have clustering of all the small bowel loops in the center. Clustering of small bowel loops in the center, and it will have a constant location. It will not move at all. It will be fixed to the center. So this is classical, and this is what we refer to as an abdominal cocoon, sclerosing encapsulating peritonitis. Clear? So that's what I showed you here, because this is a very important image to know. Whenever you see this kind of fixed small bowel loops that are fixed to the center of the abdomen, there won't be any bowel loops on the side also. This is what we refer to as sclerosing encapsulating peritonitis or abdominal cocoon. Clear? These are the four forms. Remember, the first form, ascitic form, you don't need any invasive testing like diagnostic laparoscopy and all. You can usually do it by testing the ascitic fluid, as well as your imaging itself will give you some clues, and ADA levels also will give you a lot of clue, so that you can start the ATT, antitubercular therapy. But this fixed fibrotic variety, dry plastic variety, and the sclerosing encapsulating peritonitis, in all these conditions you need a tissue diagnosis most of the time, because that's the only way to diagnose. So you might be needing a diagnostic laparoscopy. So be very clear about that. So then two types of TB that we are going to discuss in this is the oropharyngeal TB, oropharyngeal tuberculosis. And we have seen plenty of cases of oropharyngeal tuberculosis where the patient has come with odenophagia, dysphagia, or sometimes asymptomatically we have seen oropharyngeal TB where the patient will be having only a painless ulcer near the pharynx. We have seen up to the level of the pharynx also, painless ulcer. Plus in imaging, if you see, there will be an associated lymph node very commonly. that will be enlarged. Associated lymph node that will be enlarged. So this is how oropharyngeal TB commonly presents. So this ulcer, if you take a biopsy, they will show characteristic cascading granulomas and they will show the growth, your Mycobacterium tuberculosis growth in the tuberculosis culture. So sometimes we will be very surprised by seeing all this picture, but it's quite common. We have seen plenty of patients with oropharyngeal TB. It's a very common entity also in India. If you take the Western textbooks, they will tell these are extremely rare entities because their pulmonary TB itself is very rare. But in India, any form of TB is extremely common. You have to keep that in mind. Next, adrenal gland tuberculosis. Remember, sarcoidosis does not involve the adrenal gland, whereas tuberculosis is going to involve your adrenal gland. So many times imaging will be normal in adrenal TB. Many times usually your imaging will be normal. It is the high degree of suspicion that you will encounter to make a diagnosis of your adrenal gland tuberculosis. Usually what will be the picture in adrenal gland tuberculosis, because there will be TB focus elsewhere. The patient will be having a tuberculosis focus elsewhere in the body. Along with that, patient will develop adrenal insufficiency. Adrenal insufficiency. Typically, it will be a primary adrenal insufficiency and that will be Addison-like presentation. Like patient will be having electrolyte disturbance, hyponatremia, hyperkalemia, and patient may develop acidosis. Plus or minus, patient may go for profound hypotension in times of crisis. So whenever you have the TB focus elsewhere and when you have adrenal insufficiency, this gives rise to a strong suspicion that the patient might have adrenal involvement. Remember, when you do imaging, most of the time the adrenal gland will look normal. Even though textbooks will tell the adrenal size will be enlarged and you might see a bit of calcifications in the adrenal gland also, but these are not very classic. These are not specific at all for your adrenal gland involvement. But why they tell the Western textbooks give you increased adrenal size and all? Because there is another entity that produces adrenal insufficiency, that is Addison disease, very common in the Western country, that is autoimmune adrenalitis. In autoimmune adrenalitis, your adrenal size will be low, which means there will be atrophy of the adrenal glands. But in tuberculosis, they tell, and metastasis and all, your adrenal gland will be increased in size, and that is to differentiate between the autoimmune adrenalitis and the other problems. So autoimmune adrenalitis is very common there compared to TB. So that is why they tell this finding. But in India, many times imaging does not show any problem at all. The adrenal gland may look completely normal in size and structure. So this is how you diagnose adrenal TB most of the time. So there is only one option: you treat with ATT because you have a TB focus elsewhere. At the same time, you have to give hydrocortisone therapy to replace the adrenal cortisol. So this is the basic treatment for your adrenal gland tuberculosis. So I think with this we can complete this session, and in the next section we can complete the remaining clinical features of the tuberculosis.